Great. I actually made this slide as a resident or fellow, and I like it a lot. Um, uh, Not that I have to go through it. Dr. Aus did a great job talking about the hallmarks of systemic sclerosis, autoimmunity, inflammation, the progressive interstitial and perivascular fibrosis, and the vasculopathy. That even though they are seemingly separate, they're very much interlinked and differentiate scleroderma from other connective tissue diseases, and also add a lot of complexity and heterogeneity to the disease. And then in the next 18 minutes or so, let's focus our attention to vasculopathy, which has an important role in the pathogenesis and tissue injury in scleroderma. It also is detected very early on in the initial stages of the disease, where we see endothelial dysfunction, immune-mediated cytotoxicity, favorable vasoconstrictive milieu, as well as a number of pathologies that lead to an impaired both angiogenesis and vasculogenesis at many levels, including the nervous system that is, as Dr. Nuha explained, very difficult to have included in a disease pathogenesis. Of course, this is widespread and involves multiple vascular beds in scleroderma. And one important area is digital vasculopathy, which occurs in almost all patients with scleroderma and can range in severity from symptoms of Raynaud's phenomenon to irreversible ischemic tissue injury causing ulceration and potentially even gangrene. So Raynaud's phenomenon is an overactive vascular response to cold or emotional distress, and this results in cutaneous color changes and sensory symptoms as well. It was actually described very, very long time ago in 1862 by a French physician, Maurice Raynaud, in a 26-year-old female, and I enjoyed reading his description of the phenomenon. So he said, under the influence of a very moderate cold, I like very moderate cold, she sees her fingers become exsanguine, completely insensible, and of a whitish yellow color. This phenomenon happens often without reason, lasts a variable time, and terminates by a period of a very painful reaction during which the circulation is re-established little by little and recurs to the normal state. It really encompasses all the items that we look for in Raynaud's phenomenon. Of course, later on, it was realized that this can happen in isolation as a primary Raynaud's phenomenon, initially labeled Raynaud's disease, actually. But then it can also happen secondary to other reasons, as in secondary Raynaud's phenomenon. That's when phenomenon was the proper label used for Raynaud's. And the most important form of secondary Raynaud's phenomenon happens in secondary to systemic sclerosis, where it's very common. Registry analysis shows that 95% of patients or more develop Raynaud's phenomenon, and for the remaining 5% might not have the classic symptoms of Raynaud's phenomenon, but will have evidence of digital microangiopathy on evaluation. And of importance, especially in the context of a session on cardiopulmonary disease in scleroderma, Raynaud's phenomenon can predate the diagnosis of scleroderma by many years. This is especially true for patients with limited cutaneous systemic sclerosis, where Raynaud's phenomenon can predate the first non-Raynaud manifestations by many, many years. In the diffuse form of the disease, it tends to happen closer to the time of the first non-Raynaud phenomenon manifestations, namely skin fibrosis. The symptoms, as we all know, the triphasic color changes, the white yellowish discoloration that happens due to intense vasoconstriction, the blue digits that happens due to hypoxemic venous stasis, and the red discoloration due to hyperemic reperfusion. But important to know that not all patients will experience or will tell you about these triphasic changes, but most experts will agree that at least a biphasic color change is needed to establish a diagnosis of Raynaud's phenomenon, with the different colors carrying different specificity to Raynaud's phenomenon. White color is the most specific. I personally do label a patient who only describes white discoloration as Raynaud's phenomenon, very specific, followed by blue discoloration and red discoloration being the least sensitive. It can result in considerable pain and paresthesia. It can occur in other areas, not only in the fingers. It can happen in the toes, nose, ears, nipples, because they share similar thermoregulatory vessels in these vessel beds. The attacks are very variable in duration between patients and within the same patients, but can last anywhere between 15 to 20 minutes or longer, and they also have variable frequency. Of course, this is very, very challenging for study purposes and evaluation purposes. But and interestingly, different scleroderma patients can identify different patterns to their Raynaud's phenomenon, and it can progress over time, kind of owing to the progressive nature of vasculopathy in systemic sclerosis. And it can lead to the development of digital ulcerations in about 5 to 10% of scleroderma patients. Actually, studies have shown that approximately 50% of patients with scleroderma will develop digital ulcerations at some point during their disease course. And there's so much variability between studies. And like, for example, in the U-STAR cohort database, the probability of developing digital ulceration was 70% at the end of a 10-year observation period. And there are different risk factors to developing digital ulcerations, including diffuse systemic sclerosis and early onsets of Raynaud's phenomenon. And really, whether the severity of Raynaud's phenomenon per se is a risk factor for developing a digital ulceration is debatable. Around 75% of patients with scleroderma will develop their first digital ulceration about 5 years from the time of the first non-Raynaud's phenomenon. And as we mentioned, this is progressive. It can lead to critical ischemia in the form of gangrene in about 2 to 9% of patients, and can necessitate a digital amputation sometimes, which is a terrible, terrible outcome for patients. As we mentioned, it's not clear the association between whether the digital ulcerations are really due solely to severe Raynaud's phenomenon. Debatable. There are other mechanisms that take a role as well, but studies have shown that patients with digital ulcerations will report more severe Raynaud's phenomenon than those without. These digital ulcers, again, to add to the complexity and the burden of these manifestations, they are slow healing. They can, in purely ischemic digital ulcerations, which are the kind of more simple form of digital ulcers, it can take an average of 76 days for healing, and it can really last up to 810 days. And of course, if with more complicated digital ulcers or those associated with calcinosis, infection, exposure of bone and tendon, the healing is even more slow. They, for both clinical and research purposes, they try to classify and categorize digital ulcerations. Important to recognize that the etiology is variable between different types of digital ulcers. From ischemic, purely ischemic digital ulcers, these are usually the ones that we see at the fingertips. Mechanical ulcers, the kind of pathognomonic type will be the ones that we see on the extensor surface of the knuckles, like shown in figure C. We have those with mixed ischemic and mechanical etiologies, the ones that appear on the volar aspects of the digits. And then we have also those that are associated with calcinosis, like in figure D. I don't know if this points or doesn't point. Yes. Infected, and of course, gangrene. Another way to classify these ulcers, this was suggested by the CIPHER group, is by the frequency or chronicity of these ulcerations. And they can be categorized into episodic, where they happen but are very rarely to recur. Recurrent, where you have them in a number of follow-up visits, but not all follow-up visits. Or chronic, if they're present at every follow-up visits. And of course, the burden and the impact of these ulcerations increase as they become more chronic. The less studies are lower limb cutaneous ulcerations. And I don't know if any of you encountered this manifestation. Fortunately, it is rarer. I only had it in one patient with systemic sclerosis, but extremely more difficult to manage. First of all, because they have different appearance, clearly different pathogenesis. They can be due to ischemia, venous stasis, or even involvement of the lymphatic system. And of importance, these lower extremity cutaneous ulcerations tend to be associated with macrovascular disease, more commonly in patients who have the limited form of systemic sclerosis and those who are anticentromere positive. Less studied, more difficult and more challenging to treat. I'll use Dr. Noha's quote. This is another manifestation that doesn't kill you, but it doesn't make you stronger either. They do carry a significant burden in patients with systemic sclerosis. They're associated with considerable pain, increased analgesia requirements, reduced health-related quality of life, and increased hand-related disability. So digital ulcerations have shown, especially if they're chronic or recurrent, as we mentioned earlier, increased rate of impairment in activities and more need for paid and non-paid help. They usually have a greater need for interventions and hospitalization and are of cost to the healthcare system as well. Not only because of the interventions and need for hospitalization, but also because of lost work productivity as well. About 10% of this cost is due to the impact on occupational health. Now, they can help, though, in maybe improving mortality in patients with systemic sclerosis, because they can lead to the early recognition of scleroderma and potentially the early screening and diagnosis of complications from systemic sclerosis, like we'll see later especially with pulmonary arterial hypertension and ILD, the leading causes of mortality in this disease. The important factor that aids in this is the fact that Raynaud's phenomenon precedes other manifestations in scleroderma. So it's very, very important to differentiate primary from secondary Raynaud's phenomenon. And one can imagine how critical it is, because Raynaud's phenomenon is not uncommon. So registries have shown that it can happen in up to 5% of the population, with about 40% initially thought to have primary Raynaud's, developing a secondary cause to Raynaud's phenomenon over time. So differentiating between the two is crucial, and for that we need a thorough history, looking at red flags for secondary Raynaud's phenomenon, laboratory evaluation, mostly in the form of autoantibodies, and vascular investigation. So let's go through some of these. The importance in terms of from the clinical history, the age of onset. So usually primary Raynaud's happens in younger individuals. Onset will be before the age of 20. They're usually female, have milder symptoms in general. And many proposed this as a classification criteria for primary Raynaud's phenomenon. When you have an older patient, especially if the age of onset of Raynaud's phenomenon is over the age of 40, more severe episodes, associated digital ulcerations or ischemic complications, and other findings of connective tissue diseases, thumb involvement, you really have to pay attention to potentially the presence of a secondary Raynaud's phenomenon. And important also to keep in mind other differential diagnoses like acrocyanosis, vibration-induced Raynaud's phenomenon, macrovascular disease, and so on. Autoantibody testing is also very crucial to differentiate between the two, and it has a strong independent predictor for progression from isolated Raynaud's phenomenon to systemic sclerosis. I'll refer to one study, a large prospective study, more than 500, almost 600 patients with Raynaud's phenomenon who were followed for multiple years, over 3,000 patient years of follow-up. In this study, about 13 patients developed definite systemic sclerosis, and they looked at the multiple factors to determine the important ones that predicted this progression. And the multivariate analysis showed that the predictors for progression to definite systemic sclerosis are the detection of an anti-nuclear antibody by indirect immunofluorescence, about 5-fold increase in the risk of developing systemic sclerosis, the presence of systemic scleroderma-specific antibodies, again, almost a 5-fold increase in the risk of developing scleroderma, and also abnormalities on nail fold capillaroscopy carrying a hazard ratio of 4.5. This is the nail fold capillaroscopy, the most feasible way to do a vascular evaluation in these patients. There are other studies, but this is really the most commonly used due to its feasibility, ease, and it's inexpensive as well. The reason why this evaluation is possible is because, unlike other vascular beds, the capillaries at the level of the nail folds run perpendicular to the skin. So we're able to evaluate their morphology and structure and so on. And nail fold capillaroscopy now is included in the 2013 ACR EULAR classification criteria, as well as a couple of criteria that allow for the early recognition of systemic sclerosis or the diagnosis of early systemic sclerosis. As you can see here, or let's go through them one by one, starting with the Leroy-Metziger criteria that includes the presence of scleroderma pattern on capillaroscopy and scleroderma-specific autoantibodies in their criteria. As you can see, if both are present, the transition between primary Raynaud's to definite scleroderma is about 65.9% in 5 years. When both are absent, the transition is less than 2%. So very, very valuable tools to predict this transition. The criteria, the other one has two levels. The first one, the VIDOS criteria, very early diagnosis of systemic sclerosis. The first level starts with the suspicion, and they included puffy fingers. In their studies, the presence of puffy fingers had a valuable predictive value for the development of systemic sclerosis, along with Raynaud's phenomenon and potentially positive ANA. If you have any of these, then you look at the scleroderma-specific antibody and nail fold capillaries, and if one or two are present, if one or two are present, then the likelihood they fulfill the criteria and the likelihood for transitioning into systemic sclerosis is very high. And based on that, they do recommend going on to screen for other disease complications, mainly cardiopulmonary disease complications. So how can we do nail fold capillaroscopy? It can be done by multiple optical instruments, the otoscope, dermatoscope, the optical microscope as well, or video capillaroscopy. And of all of these tools, some of it might be available in the clinic, that's feasible, but the ones that had the best inter and intra-rater reliability is the dermatoscope and video capillaroscopy. Now, dermatoscope, great tool to tell you, yes, present or absent nail fold capillary changes. But the video capillaroscopy gives us the opportunity to look at magnified images of the capillaries, allowing for the quantitative and qualitative evaluation of these capillaries. So it is a handheld device which confers its own advantages because not every patient is able to be evaluated using a more static approach. Some of them have contractures, so that changing the probe is very helpful to get better images and better evaluation. And it's linked to a software that allows for the analysis of these images that we obtain. And when analyzing them, we focus on four major important aspects: the density. So the number of capillaries in 1 millimeter, the dimensions, with the focus being on the apical diameter to identify enlarged and giant capillaries, abnormal morphology. As you can see, they can be normal, hairpin shaped, tortuous, or they cross over. This is all variations of normal pathology. Or they can have abnormal pathology, multiple crosses, tortuous, or have a abnormal apex. And also the presence or absence of hemorrhages. So using this approach, which has been very, very standardized now, we can classify patients as having either normal capillaries or capillary morphology and density, non-specific abnormalities, or scleroderma pattern changes, which can either be early in the form of decreased density, but not too decreased, or actually within normal density, but the presence of giant capillaries and hemorrhages, or active, where the density is decreased with more giant capillaries, abnormal morphology, and hemorrhages, to a late pattern where we don't see clear, distinct normal capillaries. It's really all disorganized morphology due to new vascularization or new angiogenesis. They created this fast-track algorithm or rule of thumb that can really help in a busy clinic, differentiating the presence or absence of a scleroderma pattern on nail fold capillaroscopy, where you look at the density. So if the density is normal, there are no giants, then this is not a scleroderma pattern. If you see either a severely decreased density, less than 3 capillaries within 1 millimeter, or you have the presence of giant, this is a scleroderma pattern. Anything in between would be non-specific changes and will be under the non-scleroderma pattern. So this is really a quick way to differentiate a scleroderma pattern from non-scleroderma pattern. Again, important in making a diagnosis of secondary Raynaud's phenomenon and potentially systemic sclerosis. But really the quantitative evaluation of these images is not only important for diagnosis, but important also for prognosis. And we have more and more accumulating evidence that findings on nail fold capillaroscopy can help in predicting organ involvement and at baseline, as well as new organ involvement at follow-up. We have great data from the CAP prospective study and the ULAR prospective studies showing that the main parameters, so density, the capillary density, at baseline, as well as capillary loss at follow-up, and the more severe nail fold videocapillaroscopy patterns in the form of active or late patterns predict the development of digital ulcerations, pulmonary arterial hypertension, interstitial lung disease, and more skin fibrosis. This has been very much established in scleroderma, but we're seeing more and more importance to the role of nail fold capillaroscopy in scleroderma-like diseases as well, including mixed connective tissue disease and dermatomyositis. I'll just share a few slides on a study that we ran in Qatar using a small cohort so far of patients. We do nail fold capillaroscopy systematically on our patients with scleroderma and scleroderma-like diseases. This is the analysis of the first 20 patients with baseline data, where we had a majority of patients showing the active pattern, followed by 27% having a late pattern of disease. And in our analysis, although very limited due to the small number, we did see that patients with more severe pattern of nail fold capillaroscopy had a significantly more digital ulceration, which was significant. It was also seen more in patients with ILD, but the number is too small to make any conclusions yet from this study. Another potential role to nail fold capillaroscopy: follow-up, treatment response. So we also have some evidence now that maybe, including in patients with scleroderma, we do see improvement in these abnormalities on nail fold capillaroscopy with treatment. And this is a recent study that looked at multiple interventions, not only mycophenolate, cyclophosphamide, other immunosuppressive therapies as well, and showed that treatment with MMF resulted in an improvement in the capillary density over time. And studies on vascular interventions as well, mostly the IV ilioprost, also have been reported in some cases to result in improvement in nail fold capillaroscopy. And I'll again share one of my patients. It's not scleroderma, mixed connective tissue disease patient who presented with scleroderma features in addition to myositis and a positive RNP, high titer RNP, who had treatment with steroids and mycophenolate. And after 2 years of treatment, had a significant improvement in his nail fold capillaroscopy from, again, you see the enlarged and giant capillaries, ramified capillaries, decreased density, to very much normal looking hairpin capillaries with a normal density after 2 years of treatment. This got me very, very excited to see. Now, digital ulcerations or the clinical manifestations themselves also carry an important prognostic value when it comes to cardiovascular disease and scleroderma, especially the presence of digital ulcerations. And studies have shown that it is associated with an increased risk of developing pulmonary arterial hypertension specifically. This is another study that followed up DLCO over time. And although patients with digital ulcerations had a better DLCO at baseline, it did have a more significant drop over time due to the development of cardiopulmonary disease. A little bit on treatment. I'm not going to spend a lot of time on this. We do have some interventions that have been shown with either studies or mostly meta-analyses that they do improve Raynaud's phenomenon in digital ulcerations, either improve the healing or the recurrence of digital ulcerations. So mainly calcium channel blockers, phosphodiesterase type 5 inhibitors, and prostanoids, and as well as angiotensin receptor blockers. There are other interventions that theoretically make sense that they would improve Raynaud's phenomenon in digital ulcerations, but have not shown great promising results in studies like angiotensin receptor blockers and selective SSRIs, statins, antiplatelet therapy. But in clinical practice, what we do is a multidisciplinary approach targeted to the patient's needs in terms of both severity and what they're suffering from, both pharmacologically as well as by lifestyle modifications and surgical interventions as well, which we probably underutilize in many areas because of the lack of expertise. So the debridements, when it comes to digital ulcerations, have really an important role in promoting healings. I used to kind of try and minimize surgical interventions in patients with scleroderma, but with those with chronic ulcers and slow healing ones, it is probably of importance as well. And there are interventions that we previously maybe thought were more promising, like Botox injections, that recently have shown to be less exciting, again, on clinical trials. There was a study by a French group looking at botulinum toxin injections for Raynaud's phenomenon, and that was a phase 3 placebo-controlled study. Now, the good news, both groups, both Botox injections and placebo, showed improvement at 4 weeks, but similar improvement without any statistical significance. But most importantly, they did see more side effects in patients who received the Botox injections, mainly transient muscle weakness that, of course, we need to keep in mind when recommending these therapies for our patients. There is a lot of unmet needs still when it comes to the management of this disease. We need more interventions. We need to learn more about what you see missing here, immunosuppression, the role of immunosuppression in the management of these diseases. Again, fibrosis is another hallmark different than vasculopathy, but both are very, very much interlinked. And as Dr. Aus showed this morning, we do see a myofibroblast role at the level of the vessel that contributes to the vasculopathy in scleroderma. And part of the challenges, of course, is how we evaluate these patients, like Dr. Ruha mentioned. We focus on the subjective measures when it comes to Raynaud's phenomenon specifically, but will a more subjective way of evaluating these patients be of help when designing and conducting these trials? So there's a few concluding points. Digital vasculopathy is an important feature. Heterogeneous manifestations. It needs very careful evaluation because it allows for the early identification of patient with scleroderma and the diagnosis of complications that might affect mortality. Of these evaluations, autoantibodies and nail fold capillaroscopy are crucial. Nail fold capillaroscopy can also predictive of new organ involvement and treatment response, and a multidisciplinary approach is needed for the management of digital vasculopathy that we hope to see more advancement in the future years. And I'll stop here, take any questions. Thank you.